From San Francisco, this is Jane MacNeil reporting for Elsevier Global Medical News. I'm at the 50th Annual Meeting of the American Society of Hematology. Adding to concern about use of ESAs, a new large meta-analysis has found cancer patients are 17% more likely to die on study when ESAs are used.
For every 121 patients you treat in this low-risk population, one additional patient may die. And there is, of course, a confidence interval to that, which is very important and will be presented on Tuesday. If you then go to patient groups that are at higher risk, for example, the risk to die is 20% within, for example, 4 months, the number needed to harm is 34. So for every 34 patients treated with ESA, one additional patient may die. Again, confidence intervals, which I can present on Tuesday. And for a population of 70% survival hypothetical risk, the number needed to harm is 24.
Dr. Engert, you had some theories on why, the big question, why are we seeing more mortality, worse survival with these drugs that have been given for 2 decades and were considered a godsend when they were approved?
Yeah, that's a difficult question. Actually, in our first analysis, paper-based analysis that covered studies published before 2002, there were sort of borderline indications that indeed these drugs were an advantage for patients receiving EPO, a survival advantage. These were the studies published at that time, and thereafter data suggests that there's a survival disadvantage. What is clear, however, from this analysis is that patients receiving EPO have a substantially increased risk of thromboembolism, higher thrombosis risk in these patients. So if one now speculates, why is this? Why is there indeed a higher mortality in EPO patients? There are 2 reasons put forward. One is a possible tumor stimulation, because some tumors have EPO receptors, and EPO might, in theory, really stimulate tumor growth. And the second possible reason is thromboembolism. So people die from cardiac infarction, stroke, and so forth. And we personally, though we can't prove it with this data, think that indeed this is the reason, thromboembolism, because there are very source and very poor data really supporting the hypothesis that it's indeed the tumor stimulation. These are just preclinical data that might hint, but it's we don't think this is meaningful, and we will look further at our data if we can get more out of these data to further support the theory of thromboembolism.
Okay, I'm going to end with the terrible question. People who watch this video are going to be oncologists and hematologists. And I think everyone wants to know, what do they do? Are there any take-home messages, conclusions you can offer them in terms of their treatment of patients?
Well, my opinion is that the FDA has reacted during the last years to these clinical trials that did show detrimental effects, and the FDA has put more and more restrictive license indications. And the current license indication is for patients with incurable conditions with an HB value below 10, targeting just between 10 and 12. And I think that clinicians should at the moment follow the indications of the FDA, and it's up to the FDA and guideline committees to rediscuss whether these indications can remain as they are.
And Dr. Engert, do you agree?
I would say it's clear, it has become clear now that there's an increased risk, increased mortality associated with EPO. However, this risk is not huge. It's a subtle risk difference that needed 10,000 or more patients to identify. That has to be said. That's why it took so long to really find it out. So one clearly shouldn't overshoot when one treats patients with EPO, because that was aimed at in the past. Doctors tried to increase the level much higher than was needed. And if one follows the license indication right now, one is on the safer side than if one does not.